Thank you everyone for coming to our fourth community lecture event, Finding Your Path, Brain Injury and Mental Health. Each of our lecture events has focused on different aspects that relate to brain injuries, with this one focused on the intersection of brain injury and mental health. My name is Marissa Rogozinski, and I will be moderating the panel this evening, and we are very excited that you guys could all join us. Before we begin, I just have a couple of announcements. The first is that the panel discussion is meant to be an open forum of discussion between the panelists in addition to the audience. So if you have a question during the panel, please raise your hand and one of our volunteers will bring you the microphone. We ask that if you can stand up, that would be greatly appreciated. However, if possible, we ask that you save the majority of your questions for the end. We will have a section where you can ask your questions of our panelists. And I also want to let you guys know to keep in mind that this presentation will be video recorded, so it will also be available after for anyone to review or share or whatever needs to happen. So with that being said, we are going to get started. So I am going to ask each of our panelists to introduce themselves, and then we will start our questions. So who would like to start? Don't all jump at once.
So, is this thing on? Okay. Yeah, my name is Frank Jackson. I'm a rehabilitation medicine doctor and the brain injury program medical director at St. Luke's here in Spokane. I primarily work with inpatients after they've had severe, moderate to severe traumatic brain injuries as well as strokes, managing the medical issues, cognitive issues, and trying to get them back out into the community.
Hello, I'm Brian Shute, and I'm a speech-language pathologist. I work at Inland Speech Pathology. That's a practice of mine. And I do a lot of work with all sorts of different kinds of communication disorders, but do a lot with folks with brain injuries and post-concussion syndrome. And I'm pleased to be here.
My name is Amanda Salisbury, and I'm a clinical social worker. I've been in the mental health field for 15 years, and I'm also the executive director of a small practice here called Trauma-Informed Therapies, where all of our clinicians specialize in psychological trauma work.
I am John Anderson. Everybody hear me all right? Great. I'm a professor of psychology at Eastern Washington University. I'm the dean for the College of Social Sciences out there, and I'm a licensed neuropsychologist, and I used to work with a lot of individuals with head injury.
Perfect. All right, so to get this started, we are going to start with how can a brain injury impact an individual's mental health? What are some of the similarities and differences between a brain injury and a mental health condition? So feel free to start with whomever would like.
So, having a mental health disorder puts you at increased risk of having a brain injury. Specifically, alcohol use is the most common risk factor for having a brain injury. And certainly having a brain injury can then lead to having mental health issues. Most commonly depression, anxiety, less commonly things like psychotic disorders, bipolar disorder, things like that. The symptoms can often be very similar and deeply intertwined between the mental health and the organic aspect of the brain injury. Memory problems, depression, depressed mood, anxious moods, obviously. All of those things can come from the brain injury itself, and often they kind of potentiate one another. I kind of think about brain injury and mental health along with lifestyle as a triad between those three things. And oftenly they kind of work off of one another, and trying to find a way of breaking the cycle and trying to build up each of those pillars in order to really build up a person from a holistic perspective, I think is important.
I'd like to throw in a little bit on that as well. After sustaining a head injury, there's a lot of different things that can result in individuals having difficulties. So there's the organic component that can result in it. So specifically that front part of the brain, if there's a disruption there, a frontal executive kind of dysfunction that can occur that involves with emotional regulation. There can be chemical imbalances that can occur. And of course, there's also the psychosocial adjustment afterwards. Oftentimes hearing people say, I'm not who I was, and I miss that person.
So there are actually several aspects of communication that get involved with folks who have sustained a brain injury, and then also folks who have mental illness. Those things include articulation disorders, language disorders, voice disorders, fluency disorders, and then another area that we call cognitive communicative. And with the cognitive communicative aspects, folks in both circles can have issues with memory, attention and concentration, executive function skills, which include planning and organizing and creating goals and objectives for themselves, those kinds of things. All these things can be impacted by brain injury or mental illness.
I think about the similarities between traumatic brain injury and other types of trauma, and how so often, whether it's a childhood trauma or a TBI, it shifts a person's beliefs in themselves. It can shift a person's belief in others, impacting trust, impacting their systems of faith. They can start to struggle with cognitions that I'm worthless, or I can't trust my judgment, or I'm not safe. Those are similar things that we see, whether we're treating a trauma that's not related to a TBI, or whether we are treating something that is related to TBI.
Perfect. So we've kind of touched on it a little bit, but I wanted to ask what common symptomology might exist that overlap between brain injury and mental health, and if potentially, there are certain mental health conditions that, you may see more commonly with brain injury throughout an individual's rehabilitation process.
Sure. One of those things is processing speed. And this is something that, we all take for granted, the ability to think fairly quickly and to process things cognitively and linguistically fairly rapidly. And after head injury, and then also with mental illness, those things tend to be reduced or diminished from what you would see in, say, a normal individual. So the ability to think fast, and so many people after they've sustained a brain injury, or those folks with post-concussion syndrome, one of the things that they complain about a lot is that their processor is not what it used to be, that thinking is much more difficult to do quickly. Sometimes they can achieve the same point out there, but getting there takes a longer amount of time. And I can think of one instrument that I use in assessment. One of the questions on there, it's a questionnaire that you're asking the individual who's sustained a brain injury, is do you feel like you're losing your mind? And so many of those folks, they indicate, yeah, or sometimes I really do. And that's because of a lot of different things, but one of those things is processing speed. It takes longer to do, no, let me take that back. It takes longer to process mentally what used to be very quick.
So two kind of symptoms that I think about that can be common in mental health as well as brain injury. The first off, having sleep problems. From a medical perspective, that's one of the first things that I really try to address with a brain injured patient is having appropriate sleep-wake cycles. Using things like sleep hygiene, not taking long naps during the day, staying off your cell phone at night, as well as using medications to really try to restore an appropriate sleep-wake cycle. Now, that can be a result of brain injury or it can be the result of mental health. Either way, I try to treat it the same way. Another issue is agitation, inappropriate response to stimuli, so anger. Sometimes it can be crying. Agitation can manifest itself in a lot of different ways, but it can look like a mood dysregulation or mood variability going back and forth, and it can look like a mood disorder. And so often after a brain injury, it's really hard to determine if this is truly a mental health issue or if it is the brain injury itself. But nonetheless, I still medically, I kind of treat it the same way.
So often the types of mental health issues that I see when there's someone who also have had a TBI in their past typically is connected to either PTSD or depression, anxiety. When I was working for the military, active duty, did a lot of work with PTSD and TBI together, and would agree, especially with the higher levels of irritability and struggles to regulate emotionally. But I will also say that those are really common symptoms with a trauma history that doesn't include TBI. There's this concept of window of tolerance. You can Google it. It's got wonderful information, but it's this idea that we all have this window that we can tolerate where we stay in our frontal lobe, we can think through something, we can be in a conflict, and we can keep our heart rate relatively down, and we can maneuver it, and then something happens and we pop out of that window, whether we, we call it going limbic, but whether we go hyper aroused, where we have a lot of anxiety, and now our heart rate, I'm not used to wearing a mic, our heart rate starts beating really fast. We don't think all of a sudden those wonderful things that we had armed ourselves in a conflict, we can't even think of what they were anymore because we can't think through anything anymore. Or we can go hypo aroused, where instead of amping up, we amp way down, and we all of a sudden just space out. Our body becomes ultra calm, but it's almost like we're like detaching from our body entirely. And so what happens with trauma, and I see it with TBI, but I also see it with all sorts of trauma, is that window of tolerance shortens. So all of a sudden it doesn't take much to pop you out of that window to be able to emotionally tolerate certain situations.
That was great. All good stuff. I don't know what else to add, but I got one more. So just to throw one more into the mix would be something that people would refer to as a brain fog. That is difficult to really clear that up. And there's a parallel there with symptoms of depression, for example, as just one psychiatric condition. And that is you just can't think clearly, can't concentrate as long. And that's good enough, period, the end.
One other thing that I might add
Never mind.
with the post-traumatic stress syndrome, so many people who have sustained a brain injury experienced a pretty traumatic accident to receive that brain injury. So many of those things involve motor vehicle accidents or domestic violence or those kinds of things. So they walk away with a tremendous amount of, I'd say, newly acquired post-traumatic stress. And along with that comes the anxiety, and along with these things you see depression as well. But one thing too that doesn't get a lot of mention, it's something called communicative anxiety. So somebody who perhaps was very verbose, very talkative before, and had a a very comfortable feeling communicating with others, that changes. And instead of feeling calm and collected when speaking with others, instead they develop an anxiety that just takes over and causes a lot of discomfort in the communication process. Just the anticipation of picking up a telephone, for example, and talking to perhaps the person on the other end, or answering the door if somebody knocks, or even talking to a friend. You know, these kinds of things are changes as well.
One of the great things about having a panel discussion is that we get to have perspectives from different fields, different walks of life, all of that. And so I personally believe that that is important for this next question when we start talking about treatments and recovery and how that is impacted when an individual both has mental health and a traumatic brain injury. And so my question is, do these tend to be treated individually? Are they treated together? How might having a mental health condition impact an individual's treatment plan for their brain injury or vice versa? And so that's kind of where I'd like to go.
So mental illness, I would say, has a slower onset. Much of that occurs in the teenage years, and then there's another burst that occurs in the early 20s for many people. So there's this, I'd say, longer progression of that illness that occurs. With brain injury, the onset is sudden. And that's not to say that problems can't worsen over a shorter period of time, but we're looking at something that's a progressive onset versus something that is rather sudden. So how does that impact somebody who perhaps has a precondition of mental illness and then they sustain some kind of further brain insult or injury, and they're left now with that problem as well? Certainly you want to look at the history of the person. That is what we have to go on. So if somebody, for example, suffered from anxiety prior to their brain injury, or perhaps there were some other kinds of mental illness kinds of issues, that would be taken into account. The ultimate goal, the goal, is to try and return somebody as closely as possible to their pre-injury condition. You're not going to often improve a condition that has been with somebody for a long, long time, and just because they have a head injury, you're going to be able to fix that as well. So that is certainly taken into account. If somebody is working with a mental health counselor and receiving those kinds of services, certainly you would want to dovetail my treatment, for example, so it coincides with the other specialists that are working with an individual.
So I'd add that, even if someone, really truly had no mental health issues before having their brain injury, right? Post-brain injury depression is a very real thing, and it can be a new thing, regardless of truly before they had no mental health or not. It could be an exacerbation. Maybe they had mental health issues before, because we know that's a risk factor. But maybe they truly had no mental health problems before, and now they've sustained this injury, and now they have new post-brain injury depression. Because of all of these problems we've talked about having a brain injury, right? There's stress, there's loss, there's social isolation. I mean, this is the nidus of developing mental health problems like depression and anxiety. And so still needing to treat those. To me, I think thinking about the timing of the brain injury versus some of these symptoms is the easiest way. It's still not such an easy thing to be able to pull out what's truly due to the brain injury versus what's due to any mental health problems. So say you have your car wreck and you have your brain injury, and then the anger starts, and then the crying episode starts. Okay, this is obviously the brain injury. Now, person has their brain injury, they're doing relatively well, they leave my environment, they go back out to the community, things become difficult. Like I say, stress, isolation, loss. Now here come these symptoms rolling in. That to me really speaks to a post-brain injury mental health disorder. And so in trying to tease those two things apart can help in terms of developing a treatment plan for the patient.
So as a psychologist, I'll approach that from my discipline, and my treatment approach would be, it doesn't, for my discipline, it wouldn't necessarily matter what is causing the distress or the outcome. Rather, what is it that I need to help you with? What can I help you with? Why are you here? And then we'll apply interventions as we can. Now, there is some nuance in there depending if it is driven more by the actual head injury. So if there's actually an organic component, so there's structural changes in the brain resulting in that behavior, there will be some adjustments to that, but like a lot of things in life, we try again. So take out your best toolbox and try to get it to the best solution possible.
And when I think about that question, I think about, I absolutely think that it can be treated conjointly. I think it just depends on what treatment will look like when it comes to mental health. And so for anyone at any juncture seeking therapy, regardless of how soon it was after the TBI, the things that come to my mind is coordination of care, getting releases of information, speaking to other people who are on their treatment team, talking about how things are going in that perspective. But then, so often when it's closer to the traumatic brain injury, I'm so glad I'm a clinical social worker, because this is where I often do a lot of my best work with this idea of person and environment. So therapy looks a lot like, how is this impacting all your other relationships, particularly those who are caring for you, and how, is there some things that can be done within that relationship, healing that can happen within that relationship that can be strengthened. The other thing that I think about is, again, whether it's TBI or whether it's any kind of trauma work, that happens in 3 different phases. And the first phase is stabilization. And so stabilization in therapy, whether it's a TBI or any other trauma, is helping someone figure out some coping skills that they don't have currently. And so if it's high irritability, sometimes that looks like in my office, I kind of have someone think about something that's going to increase their distress. I know that sounds so weird, but it's so we can apply the coping skills we've worked on to bring it back down in session and to start building hope and building a mastery of some of those skills, right? And stabilization can also look like, how are things going with basic needs being met? Food, shelter, all of those pieces. There's a whole slew of different ways to help someone feel just from an emotional standpoint more stable. But then when we get to that second phase of like working through trauma, that's when we get into like deeper types of modalities, whether it be EMDR or neurofeedback. Those tend to be two things I often hear that helps a lot of folks who have been through a TBI when they're ready for that phase. If you're not ready for that, it can knock you on your butt, and you'll be worse off for trying. And it's not because those modalities are bad, it's because there wasn't enough therapy around getting really stable internally to handle that type of work.
So that's a good segue into my next question about how can mental health and or traumatic brain injury impact a person's psychosocial issues, so their everyday life, their functioning, their relationships, how they go through every single day. How can both the mental health and brain injury aspect impact that person?
Lots and lots of different ways.
Wow.
Yeah.
How much time do we have?
So, one of the things that I would mention, one of the aspects of language, remember that's one of the categories of communication, is a subcategory called pragmatic language. And pragmatic language has to do with the reason why you and I are talking back and forth. And it has to do with maintenance of a topic. It has to do with eye contact. It has to do with gestural communication, facial expression, being able to repair a conversation when it breaks, these kinds of things. And for folks with head injuries and folks with mental illness too, that can be difficult to do. So folks are having to deal with the pragmatic language aspects of their injury too. So you, as the non-head injured person, having to deal with a person who is head injured or who has mental illness, sometimes those pragmatic language skills can be really challenged. And so, sometimes we can refer to those as social skills, and being socially appropriate versus, quote, being socially inappropriate or awkward. And of course, people who don't have those pragmatic skills, they know that they would like to have a friend. They know that they would like to be able to communicate with somebody, to talk, but they don't know how. It's disconnected. That mechanism inside of our brains that we all take for granted, it's broken. And so, a listener might be taken back by somebody's facial expressions. For example, they're very flat and there's no expression. Or maybe their voice is very monotone and it has no intonation in it at all. People might be reticent to communicate with somebody that's like that. So that is one aspect that both groups encounter.
Anyone else want to touch on the everyday life challenges?
Wow, we talked about, the problems with concentration and memory and mental fogging, and, that can just generate so many issues in a person's day-to-day life. And I think that gets back to the importance of having a good support system, be it your family and friends, be it your therapist, your counselors, your medical team, to really combat everything that's coming from the brain injury and everything that's potentially coming from a resulting mental health problem as a result.
Yeah.
Go ahead.
Thanks. Yeah, I think about, just listening to what you said, this interpersonal dynamic, like it impacts our relationships so much, right? again, whether it's TBI or mental illness. Someone who specializes just in lots of different types of trauma work, I'll just say, like, there's this impact of trauma where it's easy to lose oneself, and you have to find yourself again, or find a new version of yourself, which we call post-traumatic growth, right? But when you feel like you've lost yourself, and and then you're in these relationships, it's so often where a significant other and friends also aren't quite sure how to connect with you in the ways that they did before. And so it can feel isolating in that way, trying to figure that out together.
To approach the whole person and the whole environment with the society that's surrounding them, it's a biopsychosocial spiritual interaction here. I mean, it really is. It's not just the biology we look at, it's not just the psyche, it's not just the social, it's that also spiritual component. And it is all of those combined. So it's not just a single person dealing with a single issue, it's a societal or a family issue as well. It's very large.
I was going to say we have to look at this from the holistic area where it's not just one thing, it's a multitude of things that can be impacted. And so that's something that's important to keep in mind. So this next question, I want to touch a little bit on addiction and suicide ideation. So just so you guys are all aware, we will be touching on that a little bit. And so the first thing I want to talk about is, does a brain injury increase both the risk of addiction and potential for suicide ideation? And also, if any of you have anything that you would like to share on either addiction or suicide ideation, stuff like that, that'd be greatly beneficial.
Yeah, I think that, well, first of all, mental health and drug addiction oftentimes go hand in hand. Folks self-medicate to try and make themselves feel better, and it turns into an addiction. Potentially that can happen with folks with brain injuries as well. If folks are, there's so much on opioids and that right now, there's more awareness of that, but for years people have been placed on pain medications that were very addictive, and they've remained addicted to those kinds of things, and then if they're cut off, then they seek that same drug perhaps on the street, and heroin use, for example, takes the place of some of the prescription medications that a person was taking before. But that component of depression that occurs with folks after they've had a brain injury, and that's a common thing. People want to feel better, and sometimes they seek drugs to do that, and it does turn into an addiction. With direction, people can find other ways to minimize their pain, and as maybe some of these things are meditation, exercise, group therapy, being with others with the same kinds of issues. These are things that are well known to be benefits to folks, but they have to be explored early on, and before a person moves in the direction of drugs and drug addiction.
I'd add in, the alcohol, tobacco component of it as well. Drug use, alcohol use increases the risk of having brain injury, and having all of these post-brain injury mood problems certainly is going to increase your risk of developing a substance use disorder or having suicidal ideation or intent afterwards. And I think that's, again, I go back to it's really important to having that team around you and having people you can trust. So that way, if you are having thoughts of hurting yourself, you need to say something to somebody, okay? Because the recovery from brain injury is going to be a lifelong process, and it's going to be a bumpy one. But that said, finding yourself in a bit of a hole because of some of these things we've been talking about, because it's going to spiral. Having a team that you can rely on to be able to pull you back up out of that and pull you out of the substance abuse, the alcohol, the thoughts of harming yourself is really important.
Yes, the answer is yes. It does increase the risk of substance abuse. It absolutely does. The other thing to keep in mind is that the brain can now, depending on the type of injury that's occurred, it can be more sensitive to the effects of things like alcohol. And so it's also something to take under consideration, is it actually can have a pretty big effect if somebody's having difficulties with concentration. Alcohol can actually then wash that down even deeper in terms of even more difficulty.
Thinking about interactions with medications that you might be
Absolutely.
taking after having a brain injury and using alcohol or other drugs, that can certainly pose life-threatening risks, something to think about. As well as, after having a brain injury, your seizure risk and whether or not you're taking seizure medications, alcohol can affect your risk of having seizures, so something to consider.
Can you go into that a little bit more?
If you haven't had a seizure after the first, so assuming with a brain injury, you haven't had a seizure after the first 7 days, typically that's when they stop the seizure medications. That said, using alcohol and becoming dependent on alcohol, there's a few life-threatening problems with alcohol, of course, overdosing on alcohol, but then withdrawing from alcohol, you can have withdrawal from that.
That's not my question.
Okay. Okay.
Can we get the mic? Is that okay?
Oh, I can speak loud if you want.
Well, the mic's coming right there, if you don't mind, just so we can. Right up here?
Aside from addiction, just alcohol use, social, not a problem, what is the risk or the correlation to alcohol intake versus the seizure activity? So for example,
outside of
1.5 glasses of wine, how will that affect a seizure?
that should not affect a seizure. If you don't have a history of having seizures, that should not affect your risk of having a seizure if it's moderate use.
Thank you.
Is there anything else we want to add on that topic?
Yeah, well, I think I'd like to come back to the suicidal thoughts. We talked a bit about the addiction, but just coming back to, like, I think some of the, the highest concerns and risk factors when we look at suicidality is the levels to which you feel social isolation and the levels to which you feel hopelessness. There's a whole lot more, but those two are risk factors that I look at first because they're highly indicating, deeper concerns. And, with that whole social isolation, I mean, it's one thing to go, start talking to someone about how you feel, but when you feel very socially isolated, that isn't so easy. And I have cards at my office, and gosh, I wish I would have brought some here, but, it can be very helpful to, at the very least, reach out to Suicide Hotline. They have text lines now, which I think is so cool. They did not have that 10 years ago, where it's completely confidential. So if you don't have a friend or a family member, or you're not engaged in systems of care to where you're feeling like you can share that, I would encourage that you share it on a text line or a hotline or something. But then if you do have someone that you can share, I would echo the sentiments to start talking about it. It's not as abnormal as one would think. When you're suffering greatly, it isn't the most abnormal thing to start having suicidal thoughts. But those thoughts aren't in and of themselves dangerous. It's when we start going down that trail, we start thinking about ways to accomplish that, we start feeling more and more hopeless. And that's where I would encourage that people start to seek out some sort of care.
And I want to reiterate a little bit about what Amanda said. If you are feeling suicidal or have suicidal ideation, there are resources for you. We've actually included some of them in your packet for you. But it's important to reach out to someone and talk to somebody because you aren't alone throughout this. And so I wanted to share that with all of you guys. So I have one more question, and I want to talk about how to optimize long-term recovery, reintegrating into what we used to do and all of that, while trying to balance your brain injury and mental health with that. And so where can our long-term potential goals be, stuff like that?
Lots of answers to that one.
There
but
it is.
One that I would bring up that seems so simple, but yet it's so important, and it benefits so many folks, and that is to develop a routine. And a routine that stays fairly stable throughout the days, and allows a person to predict what's going to happen. One of the things that brain injured folks object to, and same thing with folks with various mental illness, is change and spontaneity. Those kinds of sudden changes in a plan can throw a person off pretty dramatically. So having a routine, knowing what's coming down the pike, goes a long, long way. And those kinds of things can be just a schedule that's on the refrigerator, or a large calendar posted on the wall where the routine can be placed, and any new things that crop up can be placed on that calendar and encountered and anticipated. And those kinds of things are very helpful.
So, am I going to jump into that? Okay, phew. Didn't want to accidentally interrupt anybody. One of the things that prolongs inpatient rehab is depression. So, just one example. And so the effects, if it is a secondary effect of the head injury, one of the things is if you are feeling grouchy, low motivation to engage in things that are like personal hygiene, you're not showering regularly, and you're like, but I'm not depressed, pay attention to the people that are around you. If they're saying, hey, friend, just open up, keep an open mind about that, because making sure that getting the treatment for those types of conditions actually can improve your rehabilitation and on that road to recovery.
Trying to abstain from alcohol, drugs is important. We know that the brain needs to be in an optimal place to heal after having a brain injury, and using toxic chemicals like alcohol and drugs and whatnot is only going to slow down your recovery and diminish your full potential.
I would just like to add, not to give up, like when I think about that long-term road, there are so many different ways to heal. And there are so many different modalities out there, so many different interventions. And sometimes, it's easy to think, especially maybe if you're not in the mental health field, it's easy to think, oh, I tried therapy, it didn't work. But then my question would be, what type of therapy did you have? And not because it's a crappy therapy, but it's because it's not a one-size-fits-all. And to think about, healing from this perspective of mind, body, spirit, in your emotional health. I think about, even in my own ways of staying healthy, I think about the ways in which I carry my body, and how that impacts my emotions. When I'm doing this and thinking, oh goodness, this stupid microphone. When I'm closed like this, and thinking about something emotionally irritating versus when I have my hands open like this. That is a body intervention. I've done nothing else. I'm still perseverating off whatever ticked me off. But when I change the way my body moves, it changes my orientation towards what I feel about that. It changes the intensity. I'm giving an example to just try and widen our thoughts about all the different ways we can make changes or shifts towards health. And if what's going on isn't working, there's hope that there is something out there that will.
That muscle feedback loop is absolutely real.
Yes.
So one last thing before we get into questions, if our panelists are comfortable, I wanted to ask you guys to share maybe whether it's personal or professional, that's entirely up to you, something that you have viewed or the person you've worked with has viewed as successful, or if there is literature or research that stands out to you in regards to brain injury or mental health that you would like to share with the audience here. And if not, that is okay as well.
Well, unfortunately, from a medication standpoint, we don't have a lot of data necessarily for some of the medications that we use to manage brain injury and the symptoms that come with it. A lot of what we rely off of is from the psychiatric literature. And so while we use a lot of those medications in a very similar way, because as we've kind of all talked about, we're trying to treating it despite whether it's actually from the brain injury or from the mental health disorder. Unfortunately, we just really don't have a lot of good data to specifically say that our medications are working in the same way in a brain injured patient with a mental health disorder versus in a person without a brain injury and a mental health disorder.
So I'll throw another thing out there about post-concussive syndrome. A lot of the signs or a lot of the symptoms of post-concussive syndrome are things that you report. There's not a lab test for that. Can't just take your temperature and figure that one out. Oh, look at that. The post-concussive syndrome index is high. It's things about sleep disruption, it's irritability, it's losses of concentration, it's headaches. And if you're having those types of things, it's important to report those to your provider so that they're aware of what's going on. It can be something that I think people will feel is fake or made up. Because again, there's not an easy way to test it. So keep persisting, keep working with your providers because that is real. And even though it should clear up, it doesn't always. And there's a persistence that can continue along.
I would like to share. So when I think of a success story, someone who comes to mind that I think is so helpful in talking about TBI is this person, when I talked about the 3 different stages of trauma work, we did a lot of work in stabilization. So there was high irritability, very low ability to handle distress. And so we spent a long time working on coping skills to be able to handle that before we ever got into phase 2 of actually addressing the trauma itself. And while this person had several traumatic experiences that she did remember. She had very little memory of the actual accident that was related to her TBI, but she did know how it impacted her body, and she knew how it impacted her beliefs. We did EMDR, and the reason why we did EMDR is because in EMDR, you don't actually have to have memory to process the trauma. The way the EMDR works, it will often work through the body, how the body remembers, even if there's not a cognition, a cognitive memory of it. And so for her, she had an accident, and she was very skilled in this area that she was working in. And then she had a horrible, horrible accident. So for her, it impacted her ability to trust herself, that she felt like she couldn't trust her ability to make good decisions. And that cognition, I can't trust myself, impacted her in all of these other different ways. So by addressing that trauma, even though she didn't have a lot of actual memory around it, by just addressing how it impacted other things related to it and how it impacted her body, she was able to get to a place where she fully trusted herself. And she was able to work through ways in which she realized her actual body was impacted by that trauma, whether it was increased anxiety around things that reminded her of that accident. Not that she had a memory of the actual accident itself, but she knows the outcome of that. So anyways, I just wanted to share that story. I'm being very, very, very careful to not share too much details, but what I want you to take away is there is a lot of help out there, even if you have all these symptoms and no memory of what happened.
So I can think of two unique people who were in accidents and sustained a brain injury. Both of these people had some ability to play a musical instrument. After the injury, they couldn't read music. They were having troubles even picking up their instrument to play. But then something mysterious occurred where those skills returned, and then returned even better. So I can recall a gentleman that I saw just amazed at what he could now do on his electric guitar. And another individual had expressed to me that, as she was playing her instrument, she had to always concentrate on reading the music and that kind of thing. But after the head injury, she could now play the instrument and have a conversation with somebody at the same time. So some unique changes that were mysteriously favorable in those two folks. Something that I work a lot with is attention process training. That's a program that was developed some years ago to assist in the attention and concentration issues that hand-injured folks have. And as we're moving through that, it's a progressive system that increases in complexity. When people are seeing the improvements that are occurring, well, I wasn't able to do that last week, but now I am. When they're able to see that progression of improvement, that's a real boost for them. The last thing that I'll say is that if a person is head injured, they should be encouraged that things are not going to stay the way they are. The brain is plastic, it is teachable, it is changeable, it does change over time, and the research suggests that if you take somebody and you follow them over time, there's going to be changes that are improvements across time. So things don't necessarily just stay the same, they get better. And especially if there's intent. If there's intent to improve, the universe is going to play well and is going to help you improve. So where there's intention, there can be improvement. Where there's awareness, there can be improvement. And that's one of the things that healthcare providers and therapists can provide, is that feedback that allows you the information to improve. You know, sometimes the average person, they know something is wrong, but they can't put their finger on it. And maybe there are several things that are wrong all at the same time, and they can't really put their finger on it, but a specialist can pinpoint those things. They can explain what the problem is, and if you know what the problem is, there's a far greater chance that it's going to improve. So encouragement is an important thing. Be encouraged.
Perfect. Thank you so much. So now we are going to open up the floor for questions. I want to remind everyone to please raise your hand, and we will have a microphone brought to you. And if you could please stand so that it's easier for everyone to hear and see you, that'd be greatly appreciated. So we're going to start up here, it looks like, if possible, yes.
What response do you recommend is appropriate when discussing the processing speed issue to a non-brain injured person when that individual discounts it and relates it to his or her own aging, or what I would say overstressed cognitive dysfunction? That is a very common, I'm sure all of us in here can relate to that, and I'm curious what would be like socially acceptable. I haven't quite figured it out yet.
So you're referring to like denial of problems?
No, when I'm explaining to someone when I have a processing delay, when I'm attempting to explain it to someone, they discount it and go, oh, that happens to me all the time. Okay, it's not the same thing.
Yeah.
Did you hit your head? Do you
Yeah.
have a brain injury?
Yeah.
It's not the same thing as I'm old or I'm aging or I'm just super stressed and I've forgotten something. It's a completely different phenomenon. And so I'm wondering, does anyone in the room or you guys here on the panel have a recommendation as to what might be an appropriate response for someone like me with a brain injury who can respond back and say, no, it's really not the same thing, but not be snarky?
Yeah, so I think people as a general rule, they want to be nice. And, you know, if you have a complaint, whatever it is, oh, I've got that same complaint too. I can't remember the names of people, or I can't remember the names of my family members either on occasion. Don't worry about it, you're okay. But it's different for you. And with a smiling face and a kind demeanor, you can say, you know, it's because of a brain injury that I sustained. And so it's not quite the same. And this gives you an opportunity to educate the person that you're conversing with.
Usually no, because I'm explaining to them. Then they still proceed with the,
Well, you can only go so far with anything, right? So do your best with a smile and help educate people. Head injury is a misunderstood thing, and I've had so many people say to me, no one understands what I'm going through, and I try and explain it, and no one understands. I feel isolated out there because no one knows what I'm going through.
well, you can't see it.
You can't. No, and so often a person looks completely normal, they walk completely normal, they dress normally, but there's that piece of the iceberg underneath here that no one else sees, but you feel, and that's what you're dealing with. But, you know, it's a good opportunity to educate people on brain injury. People don't know about it, and no one better than somebody who's experienced the problem to share how it really is.
So we have another question over here.
Couple of questions. One is, what is EMDR and the 3 stages of therapy? And second thing is how to motivate a person or give them sense of hope that, yes, I'm going to get better. especially when they have a frontal lobe deficits and, initiation and such is a problem. Because you made a wonderful point about, kind of saying people, with intention, people do improve, but how to help with that?
So EMDR is a long acronym. It's eye movement desensitization reprocessing. It's one type of therapy that's used to reprocess trauma. There's a lot of therapies out there, and that's one of them. The reason why I mentioned it is because it does do a good job at capturing traumatic trauma that when there are no words or memories, but the 3 stages of trauma work is universal to whatever kind of treatment that you're going to do to actually address or reprocess the trauma itself. That first stage is being stable enough to handle reprocessing any kind of trauma. There's reasons why people might anesthetize the pain because it's too hard to deal with, right? It's going into that dark hole, and there's a strong desire to want to avoid that because we want to avoid pain. And so stabilization is about being emotionally stable and socially stable. It's about making sure that you are able to handle that and not spiral further down. But then when you are, that second stage is finding a goodness of fit, finding the right treatment, type of trauma treatment for you. So the top 3 most evidence-based practices for trauma work for PTSD is, for instance, is EMDR, prolonged exposure, and trauma-focused CPT. I'm trained in all 3, and I can tell you all 3 of them are very, very different. And I'm so glad because not one size fits all. And there's so many more therapies than even that. But that second stage is when you're ready now to deal with the darkness, to deal with whatever that traumatic content is that you want to reprocess and re-deal with, like how has it been impacting your cognitions, how has it been impacting your body. And then that third stage is, that past work has been done, and now it's about having the type of future that you're wanting to have. What kind of life what kind of changes do you want to see in living your best life? That's that post-traumatic growth, right? So some of these shifts in the beliefs about self, about others, whatever got shifted to a place where it was harmful is now like into a better place. And now how does that, like that alone, when those shifts happen, that also changes relationships. It changes our relationships with ourselves, our relationships with others, what we feel like we're capable of doing, so on and so forth.
I have a question right here. Oh, hold on, right there.
Okay, calling and talking to someone you don't know or see can be very scary. Talking about suicide prevention. If it's too much for me to handle, how can I expect someone else to handle it? They really don't have answers or solutions, so now I feel even worse, and there's the fear that what if they threaten to lock me up if I can't handle it? Second question would be, how do you find the help out there? It's not easy. How do you have suggestions about stages? And part of that is, oh, your insurance isn't accepted here, etc.
Those are great questions. The first one there, it's scary to talk to somebody who I don't know, though I'm not familiar with, there's no easy answer to that one. Is there somebody that you do feel comfortable talking with, and is it actually worse to talk to somebody that you're not familiar with than to not at all? And then you're talking to me right now, right? So who is a safety net, who is a safe person that you would feel comfortable talking with, and reach out to them. But I do agree, talking about sensitive issues on somebody on the other end of the phone, you have no idea who they are, can be hard for some. I will say on the other side of that, some actually prefer it. What was the second question about?
How do you find the help out there? It's not easy. Do you have suggestions?
Well, I think events like this are actually a fantastic step forward in that. The organization did a great job putting together a resource fair about different access points here in our community, and I know that there are more and more that are going on. So I'll kick it over to the others in the panel.
Yeah, some of the resources that I really like locally, there's what's called the Mobile Crisis Outreach Team. They're through Frontier Behavioral Health. And what I like about the Mobile Crisis Outreach Team is that they meet a person where they're at. So if they're struggling with suicidal thoughts, like if they just want a daily phone call, then that's what they do. If they want to meet somewhere, that's what they do. If they want them to come to your home, that's what they do. If you want to go to them, that's what they can do. But they just do a really good job at being client-centered and trying to take a person with where they're at and doing whatever steps that are possible. And that day-to-day check-in can be so very helpful.
The MCAT. MCAT is what you're referring to.
Yep.
And that is a tremendous resource in our community, especially when things get really critical and really bad. They can help. And typically, if they go to somebody's home, there is a trained specialist, and then there's like a peer person, somebody who is encountering the same kinds of things, or who has encountered the same kinds of things that perhaps you have encountered. They are great, and that's through Frontier Health. MCAT.
Thank you. So we're gonna go back here, and then we're gonna come up here.
What about like reoccurring stages of grief? I mean, like you tackle an issue, but then new issues arise. So it's sort of like you don't need a constant therapist or something like this, but an occasional therapist?
That happens.
Yeah, I mean, just, you know, I mean, there's different issues. My brain injury happened a very long time ago, but there's still issues that come up. So I'm asking for solutions or direction, or how do I tackle?
Yeah, so therapy can look all sorts of ways. There can be long-term therapy, there can be brief therapy. There's absolutely that ability to have like someone come in and out depending on their need. There's also like, it doesn't have to be therapy. Like there's a lot of ways in which people seek support through peer groups, through process types groups. There's grief-orientated groups.
I just was wondering, is there a correlation between TBIs and onset or early onset Alzheimer's or dementia? Do we have enough data?
It's debatable. Very debatable. No, there's not good data. Even the chronic traumatic encephalopathy, it's debatable data, and it's a really hot topic right now with football, and that's still a pretty debatable thing, and that's a lot of trauma.
So the question I have is that when you have a loved one that you know has had many concussions over the years, and you see so many of the symptoms that you all have talked about this evening, but they're not a doctor in medicine or psychology, and how do you persuasively, gently motivate them to go be seen and evaluated? What's that step look like?
Gently, gently. I think that's a predicament, a dilemma that a lot of people encounter. It's like, how do you help somebody who doesn't want to receive help? And I guess gentle persuasion and doing it with kindness is the way to maybe approach it, maybe doing it together. Sometimes it's less intimidating if, you know, a husband and wife, for example, can go together for whatever therapy, for whatever the problem is. Going at it alone is intimidating for a lot of people and scary. And so the other thing too is that mechanism inside of our brains that allow us to know that there's a problem. Sometimes that gets broken. And anosognosia is one of the conditions where a person can't see what their own deficits are. That system in their brain is not working. And when you're going up against that, trying to convince somebody, yeah, there's a problem here, and you're not seeing it, you know, then it can cause some anger issues. So gentle persuasion.
If you frame it in the theory of the stages of change, it's somebody in a pre-contemplative stage, right? So it's somebody who isn't even contemplating the idea that there's a problem. Usually it's an external force that causes somebody to push it into that contemplative stage. It doesn't mean that they're willing to change. It means that they're just contemplating the idea of. But it is that actually begins to move towards the planning and the action and the maintenance. So it is usually those gentle forces, and you can't drag people to water.
And I would say like a gentle force could be maybe just describing your experience, just to be able to share, like, this is what it's like for me to watch you suffer. This is what I go through. This is my experience, right? Sometimes the motivation can come through out of care of that relationship. They might not feel like it's worth it themselves, but if they knew the true impact in people they care about, and I don't mean to be manipulative. If it's not the case, don't lie. But to really be honest on a heart-to-heart level can be really helpful to hear.
Thank you. All right, right there.
So my question was, I was diagnosed in December with in May with post-concussion syndrome, and then later on they think that I might have a TBI, and I've been playing the waiting game and I'm getting kind of frustrated because I'm in school now. I'm in the master's program for social work, and I am really struggling cognitively with speech therapy, and I've been trying to advocate and stuff like that because it's really affecting school. So my question is how long does this process go, and what am I looking at and stuff like that? Because when I ask my doctors and stuff like that, they don't really tell me anything, and I don't really have any advocates, and I don't have very many supports. So that's why I'm here to find out information and stuff. And I'm just curious because it's kind of scary and it's kind of frustrating and it's overwhelming at the same time because I want to do really well in school, and it's hard with this TBI or whatever you want to call it. Yeah.
If you haven't already, most of the schools, all of the colleges have an Office of Disabilities where you can receive accommodations, and maybe I'm I'm talking to the choir. Maybe you already know about this. But for those of you who don't know, if you're trying to get back into school and make a go of it, oftentimes through the Americans with Disabilities Act, the ADA, you have the ability to have things accommodated and adjusted. So test taking or more time to do assignments, those kinds of things to accommodate your success. But of course, if you don't know about that, then you're muscling through. You do know about that, and you're still muscling through the process. So returning back to school is something to be taken very seriously, and taking small bites rather than large bites. Big bites are really hard to do. And of course, the motivation to get through the program fast. I need to get done with this. I'm tired of messing around with this. Yeah. I think success is taken in small little bites, and not, treating yourself well as you're going through school, getting good nutrition, getting lots of sleep, having a good support, and moving. It's okay to move slow, There's nothing wrong with going slow. I hope that's helpful.
I have the microphone. I had my brain injury in July. I didn't even know I had a traumatic brain injury until I was about to be released from St. Luke's. And I said, I'm so glad I didn't have a traumatic brain injury. I just had a little brain bleed. And she looked at me and she says, yes, you did. You had a traumatic brain injury. So now I'm feeling much more pitiful than I was before. But at the same time, I'm released from St. Luke's, I'm back in my life, and 2 different people recommended to me a book called Why We Sleep. I have been I worked restaurants from the time I was 16 until I was almost 40. I worked nights, I drank coffee late, I drank beer late. Then I read this book, and it talks about how your brain really works and how sleep really works and what happens in sleep. The worst things you can do for your brain are drink coffee because it wrecks the circadian rhythm if you drink it late. Drink alcohol, it wrecks the circadian rhythm. You don't get your REM sleep, you don't get your deep sleep. That's where you remember things. That's also where your wounds from the day before sort of get flushed out and you get renewed. I was thinking for all my adult life, and I was a public school teacher, I get by on 5 hours sleep, that's good enough. It is not good enough, because when your brain really works, it's the hours right before you wake up, and that's where you remember things, that's where you have brilliant epiphanies, and I'm not hearing a whole lot about sleep. So I'm back home now, and I love to drink my wine while I cook. And then I read that book, and now I think, well, I'm just setting myself up for bad sleep. It's the truth. I knocked off drinking. Going to St. Luke's and the hospital will just sort of knock that right out. I do sleep better. And I make myself stay in bed longer so I do get sleep. And I have a Fitbit that shows when I get REM sleep, when I get deep sleep. It makes a huge difference. A huge difference. And if you want to remember things, you got to have REM sleep. So I'm just saying, check out how long you sleep and try to extend it. And if you need to know how to do that, read that book. It has it all there. And of course, it's like everything. It's easy. Well, the steps are laid out for you, but it isn't easy because you have to change habits.
Thank you.
So I'd like to say thanks to Dr. Jackson, the physiatrist on the panel, then for talking about the importance of sleep and when he's working with his patients, making sure that he's establishing that. So thank you for your comment.
Yeah, definitely. And thinking about going online, you can just look up sleep hygiene, and it'll give you a lot of those similar recommendations that I'm sure that are in that book.
Okay, so we have a question back here.
So my question is, somebody mentioned post-traumatic growth. I forget who that was, but I was wondering two things. One, is that only limited to TBIs or brain-related injuries, or can that be across all kinds of trauma? You guys are nodding your heads. I'm assuming that's yes. And what are the first steps or interventions that you can take both in the hospital and out for discharge to promote that kind of growth in patients?
Yeah, so post-traumatic growth is it is absolutely any type of trauma. And it's this idea of, sometimes our lives can be more enriched and bettered from these hard things that we go through, right? We have deeper empathy in a different way for ourselves, for humanity. When we have to, grapple with really difficult, vulnerable feelings and beliefs and to learn how to shift that's not easy, because that's not just thinking it, because we all can think those things and we can even believe them in our mind, but if they haven't gone 12 layers deep to our body, to everything where we truly know that we know that we know we're worthy, that we're whatever it is that we're needing to know, your particular journey to getting there, where it's all so different, that journey of healing to getting there, but in doing so, the outcome is greater than if you'd had never gone through that really hard thing.
I would just say, oftentimes I refer to that post-traumatic growth as the new normal. What is our new normal? Mm-hmm. That term, I think, comes out of the bereavement literature, actually.
So we're going to take two more questions. So we have one over there, and then we'll do one up here.
So my question is there a difference between two patients that are healing from mental illness versus TBI? Does that make sense?
One more time for me.
Okay.
I'm slow, sorry.
It's all right. Is there a difference between two patients healing from mental illness versus TBI? Or, like mental illness after TBI versus that slow onset mental illness?
So I'm going to say that everybody is very individualistic here. It's really hard to dichotomize it that way, unfortunately. I think it's important to approach every person as their unique self. I think as others on the panel have said, there's not a one size fits all. It's try to work with the toolbox of what we have to be able to provide the most effective treatments with the person that's sitting with us.
And then when we're talking about healing, is that really adjusting to it, to the brain injury? I'm a brain injury survivor, so I find it being more of an adjustment to it. Like, I'm never leaving it behind. No matter what I do, it's not leaving me. You know what I mean?
Right.
No, healing can heal. You're talking about adjustment versus healing. Well, certainly adjustment is healing, or an aspect of healing, but there are definite things that do indeed heal with treatments for brain injury.
And
Does
when
that
you
make sense?
when you say healing, that means like getting rid of it. Or, that's not the words I really want to use, but it's removing it or going back to how you were before.
Yeah, so, for example, somebody sustains a head injury, they're unable to calculate addition and subtraction problems. You start working on that with a patient and it gets better. Okay. And there's an improvement there. That could be considered healing. Somebody who, for example, can't name the items in their kitchen, 6 weeks later, they're able to name those things successfully. That would be considered healing.
I think something to note about healing is that healing can mean so many different things to so many people, just like how your brain injury can be completely different from one person to the next, or there can be similarities. And so it can be difficult to give a one-shoe-fits-all type scenario where it can answer everything necessarily. And so that's sometimes something we have to keep in mind for all of these scenarios. So we have one more question that we're going to do right up here.
Thanks. I'm a caregiver. My person has severe expressive aphasia and cannot express themselves with language. So what kind of treatments are there available for those feelings of loss and isolation and depression?
There's a lot of great things out there. Technology and apps on the smartphone. Some of those things are very easy to use, and if you go to Google and type in apps for expressive aphasia, you'll get a listing of several. Something as easy as a picture board. Some of those are commercially available, and then others can be made very easily where a person, if they have the total inability to communicate orally, they can use a pointing type system to convey needs, thoughts, ideas. There used to be a little booklet called a Daily Communicator that was, in fact, I think you can still get them. And I mean, it's totally analog and just paper kind of thing, but it's just like a flip book where, men's needs, clothing needs, and all these kinds of things are indicated there in short little words. And this is provided somebody can read short words. But I mean, there's all sorts of things out there to help with that communication for somebody with expressive aphasia.
I would also like to draw attention to, for the caregivers out there, that your own needs are also important. It's so easy in a caregiving role to give your energy to what's considered the greatest needs at sometimes the expense of self. And to be able to, going back to the whole being on a plane, putting the oxygen mask on yourself first, there's some realities there that you're going to caregive better, you're going to do everything better when you're able to take care of your own self really well. And that's really hard to do sometimes as caregivers. I'm a caregiver, and I'm in a caregiving field, and we talk about self-care all the time, and we're notoriously terrible at it because we're wonderful caregivers. But it is such a real thing to be able to really attend to yourself in that role as well.
Yes, that's a great point. So before we end the night, I have a few announcements. I first want to ask if everyone could fill out their evaluations that you received, and if you didn't receive one, there's some at the check-in table. These evaluations help us to plan future events and try and meet the needs of what the community may be. And so that would be greatly appreciated. And when you're done, if you could turn it in at the check-in table, that would be greatly appreciated. My second announcement, if you haven't done so already, please feel free to visit all of our resource exhibitors. We greatly appreciate all of you for being here because you provide such wonderful information for everyone that's in attendance. I also want to let everyone know that on Saturday, March 14th of this coming year, 2020, we will be hosting a one-day symposium at Marabou Park Hotel, and we'll have a wide range of presentations and workshops, and we will be posting more information on our website at nwbis.org. The information is also on the program handout that you received when you checked in. And last but not least, I want to thank our panelists, our exhibitors, the staff that I get to work with for putting on these events, as well as the library for hosting this with us. And so thank you all for coming, and enjoy the remainder of your evening.